Primary healthcare practitioners have a key role as part of their routine everyday practice in the control of STIs. Most STIs can be managed well in general practice, and support and referral options are detailed on the local primary healthcare network's Health Pathways site. In the case study, Matthew is a 26-year-old gay man attending a primary healthcare setting. Matthew presents to the clinic with symptoms. Hi Matthew, lovely to see you. I haven't seen you for a long time. How are you?
I'm okay, but I'm concerned something is not right down there.
Well, thanks for coming in. To help you, we're probably going to have to talk about sex and get quite explicit. But I assure you that there's going to be no judgment, and it is safe to talk here with me. Do you have any concerns about that?
No, I'm okay to talk about it. There's a thick yellow discharge coming from inside my penis, and it's coming from inside my urethra.
How long has this been happening for?
It's been about 2 days.
Is the discharge profuse or just a bit scanty?
There's so much. I have tissue papers inside my underpants and to try to absorb this discharge that's coming through. And the discharge now is actually stuck to the tissue.
Do you have any other symptoms like tingling inside your urethra or pain when you're passing any urine?
I've got this funny, odd sensation, almost like pins and needles inside my urethra. It's tingling, it's uncomfortable, and a bit painful to urinate.
When was the last time you actually did have sex?
I met this guy earlier in the week, and we had sex on Tuesday around lunchtime, and I noticed the discharge on Thursday night.
I see. So the discharge started just a couple of days after you last had sex. Just so I need to know what tests we need to do, I need to know a little bit more about the kinds of sexual activity that was involved. For example, did you put your penis in his bottom?
Yes, and before you ask, we didn't use a condom.
Did you have any oral sex where your penis was in his mouth?
Yes.
May I ask, when was the last time you had a sexual health screen?
I'm on PrEP, so I get tested every 3 months at the PrEP doctor. The last time was 2 months ago, and my results are all fine.
Well, if you don't mind, I'll have to take a look and then order some tests so we know exactly what's happening. Neisseria gonorrhea is a causative organism for gonococcal urethritis. More than 90% of the time, urethral gonorrhea is symptomatic. Patients usually present with a thick yellow discharge coming from their penis. Gonorrhea has a very short incubation period, with the majority of patients presenting with symptoms just 2 to 3 days after their last sexual exposure. So a small study at Melbourne Sexual Health Centre found that less than 10% of patients who have urethral gonorrhea are asymptomatic, and they're merely diagnosed on nucleic acid amplification tests on their urine. So these patients, a small minority, do not present with symptoms. Notice there are no lesions, blisters, ulcers, or rashes in this picture. It's just a purulent discharge that's emanating from the penis, and it may drip from the penis or it may be contained within the foreskin. And patients may put tissue paper there to try and absorb the discharge so it doesn't stain their underpants. The discharge is often the pathognomic sign, so they may or may not have dysuria, or they may or may not have urethral tingling. And when you pull the foreskin down, you'll see this thick discharge with associated myotitis, which is actually inflammation of the urethra. So in this situation, I would conclude that there is a high suspicion of this being gonorrhea due to the purulent discharge and the tissue paper sign, the onset soon after the exposure, 1 to 14 days, but around 3 days. He's a gay man with a high prevalence of gonorrhea in the community. To summarize, the clinical approach is to first start with a history that's based on the symptomatology, their last sexual contact, and their gender source. Then proceed to the examination where you look at the urethral discharge and then also look at the urethral meatus. If the patient's last sexual contact was just a couple of days ago, this suggests gonococcal urethritis. But if their last sexual contact was 10 days to 2 weeks ago, then it's more likely to be chlamydia or Mycoplasma genitalium. These are the 3 common organisms. To confirm gonorrhea by testing, a first void urine specimen is done. It doesn't have to be the first void for the morning. Preferably, it's usually 2 hours after their last void, But if they've just voided and they need to have taken another specimen immediately, please don't lose the opportunity because the tests that we do are very sensitive. You should do a swab of that discharge and send it for microscopy and culture for Neisseria gonorrhea, because that will tell us for sure that this is viable gonorrhea, as well as tell us what's the best antibiotic to use for this patient based on the antimicrobial susceptibility testing. So before the first pass urine is collected, make sure you do the smear, the discharge for gram stain, as well as microscopy, culture, and sensitivity. So you need to swab the discharge mainly. No need to swab the urethra. This will be very painful for the patient. We'll do a first pass urine for gonorrhea and chlamydia. I may order a Mycoplasma genitalium test on the first pass urine if the patient has non-gonococcal urethritis type signs and symptoms, where the discharge is scant and gonorrhea is not suspected. We also need to screen for other STIs at sites where sexual activity occurs, like the pharynx and the anus, because often infections occur together. A blood test for HIV and syphilis, as well as other blood-borne viruses, should also be considered as part of the testing process. This is the gram stain of Matthew's urethral discharge. Looking at it under the microscope, you can see polymorphs, and within the polymorphs, there are some gram-negative diplococci, which are present both inside and outside the polymorphs. And you may or may not have the luxury of seeing this under the microscope. But basically, once the laboratory technician sees this under the microscope, she knows for sure that based on the history, the examination, and the slide results, these have a high positive predictive value for gonorrhea. So Matthew, your test results are back. Your urine test is negative for chlamydia, but it's positive for Neisseria gonorrhea on the nucleic amplification tests that I did. It's called a NAT test. We did a gonorrhea culture as well, and we found that Neisseria gonorrhea was isolated. And of course, the sensitivities are also reported, which tells us which antibiotic would be best to give you. Do you have any questions before we proceed?
What's the best treatment for me?
So the treatment of choice is the standard of care. You need an injection of an antibiotic called ceftriaxone. The injection can be quite painful, but I will reconstitute the ceftriaxone powder with some local anesthetic, which will help reduce the pain at the injection site. Do you have any new allergies to any medication since you were last here?
No, I'm not allergic to anything.
Okay, so you ready for your treatment?
Well, I do want this cleared up, so let's get on with it.
The new treatment guidelines for gonorrhea include ceftriaxone, 1 gram, mixed in 2 moles of lignocaine. Dual therapy is no longer required with this higher dose of ceftriaxone.
Yeah, that did hurt a bit.
Oh, it'll be okay soon. The injection actually went well, so it'll settle down soon. So Matthew, my advice, please don't have sex for the next 7 days. I would be asking for a longer period if drug resistance was suspected, but the test suggests that that's not an issue. Will 7 days without sex be an issue for you?
No, that's fine. I've gone without sex for 7 days quite often.
And it's my responsibility to ensure that contact tracing is done. This is important to curtail the spread of the infection. Are you able to contact your sexual partners in the last month and let them know to get tested?
Maybe.
You can either tell the partners directly yourself or do it anonymously through the Let Them Know website if you prefer to do it that way. This information is available on our website. Sometimes that's important for your own personal safety. I can help you with that if you like.
No, it's okay. It's really important that I let them know.
In a situation like the role play you just saw with Matthew, the clinician would need to propose a full STI screen as well as focus on the presenting symptoms, which in Matthew's case suggested gonorrhea infection. VHITAL runs a course on syndromic management of STIs, which outlines more comprehensively how STIs actually present in the clinic and how best to manage them as part of routine, everyday primary healthcare practice.